Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Today I'm going to cover a couple of fairly commonly used antidepressants that can be used for multiple other things as well, but want to cover Mirtazapine as well as Bupropion on this podcast episode. Before I get into that, go get your free 31-page PDF. Absolutely a no-brainer. Simply an email will get you access to that. You can do that at reallifepharmacology.com. It is on the top 200 drugs. Some of the most important things you're going to see in practice as well as on board exams is on that free 31-page PDF. So go take advantage of that. Simply an email will get you access to that at reallifepharmacology.com. All right, let's get into the two medications, the two antidepressants I want to cover. Really going to hammer home the most important test prep pearls as well as things that actually occur out in practice. So Mirtazapine first is Remeron. That's the brand name. This has noradrenergic mechanisms to it, so kind of that stimulatory effect. But it also has strong histamine blocking effects as well. So that can kind of work on the flip side of sedation and weight gain and things like that. We've also got some action on blocking some of the serotonin receptors, 5-HT2, 5-HT3, and that can kind of shift serotonin activity around a little bit there. So thinking about the mechanism, that really helps me understand the adverse effect profile. So first off, the histamine effects or the antihistamine effects blockade, that is going to lend towards sedation, and that tends to be more stronger than the noradrenergic effects or the alpha-2 antagonism, increasing norepinephrine, those type of effects in the central nervous system. So what that means in clinical practice, having a little bit more preferential binding to the histamine receptors and blocking those receptors, that's going to be the first effect that you see. And in practice, I always remember being taught that antihistamine effect happens a little bit more at lower dosages. And then as you get to higher dosages, you may get a little bit more noradrenergic effects and maybe a little bit more stimulatory effects. So what that means in practice is at doses 7.5, 15, maybe up to 22.5, we may be more likely to get sedative properties of the medications than as we escalate dosages, which that's kind of counterintuitive for most medications. Usually you increase the dose. For a sleep medication, you're going to get more sedation, and so that's kind of the theory of why when you escalate the dosages of Mirtazapine, you don't necessarily get an increase in the sedative properties of the medication. Now, I say this all with a grain of salt. I've seen plenty of unique things in practice, different responses, those type of things. But if you find yourself increasing the dose of Mirtazapine because the patient's having trouble sleeping at night and that it's not getting any better, it could be because of that mechanism and the way the medication works. So hopefully that makes a little bit of sense, but again, those lower dosages may be a little bit more sedating type properties. And the weight gain component too is something I want to speak to. So in a patient that's looking for an antidepressant, the weight gain can be problematic. Many of these patients, or a significant chunk, can be overweight already, or weight's an issue. In that situation, Mirtazapine is not necessarily a really, really good choice. However, I do occasionally have a few elderly patients who are not eating well, and they have signs and symptoms of depression. The appetite stimulation, the weight gain effects of Mirtazapine, coupled with the antidepressant type effects or whatever we're trying to treat with this medication, that can be a beneficial thing in patients who are underweight or not eating well. So Can be good or bad, again, depending upon the patient situation and that weight gain, appetite stimulation piece of the medication. All right, highly, highly testable clinical pearl. This medication is one of the preferred ones, as well as bupropion, which I'll talk about coming up here. It causes a lower risk of sexual dysfunction compared to SSRIs and SNRIs and TCAs. Okay, so if you have a patient that's having a lot of trouble with that, let's say they start sertraline, for example, they're complaining of sexual dysfunction, sexual impairment, that could definitely be a potential resolution where we switch them to mirtazapine. Okay, so just kind of a general overview of side effects. That sedation is problematic or can be problematic. It can be helpful too if we're looking at managing insomnia or trying to help that complication from depression or by itself. Weight gain, again, can be good or bad. The increased appetite can be good or bad, depending upon the specific patient that we're looking at. GI adverse effects are possible. Not something I see dramatically often with mirtazapine. You may see some dry mouth, constipation potentially. Usually that's maybe a little bit more so at higher dosages. Dosing, usually 15 to up to 40 milligrams is kind of the standard dosing I see. In geriatric patients, sometimes we'll start them at 7.5, just to be a little bit more conservative, or if we're, concerned about over sedating them or whatever the case may be. Occasionally I see up to 60 milligrams. I can't recall more than maybe a case or two where somebody actually used above 60 milligrams. But again, most often you're going to see probably 15 to 45 milligrams being kind of that target dose with that medication. So coming back to, where we're going to see this in clinical practice, the ideal fits for this medication, obviously we've got a couple of compelling indications. So if patients have, depression coupled with insomnia, the sedative properties of mirtazapine could certainly be helpful there. And the other one is depression plus, poor appetite or weight loss. So those two are really the most common situations I see it used in. The other one I will mention is sexual dysfunction. So if we need a medication there to help with that, or they didn't tolerate an SSRI, we still need an antidepressant, that's definitely a situation where you're going to see this medication used as well. All right, let's take a quick break from our sponsor, and we'll wrap up with Bupropion. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, the psychiatric exam, BCMTMS, go check out meded101.com/store. Your support there goes directly to help support this podcast, and I greatly appreciate it. In addition, if you're a med student, nurse, pharmacy technician, we've got all sorts of medication education to fit your needs. So go check out all the links, meded101.com/store. All right, moving on, we've got bupropion. Brand name is Wellbutrin. This is a norepinephrine and dopamine reuptake inhibitor. So you'll notice that serotonin isn't in the name of the class of this medication. It's really a standalone medication. There's nothing that really, works very similar to this medication. Ultimately, it inhibits reuptake of dopamine and norepinephrine. So it's going to increase concentrations of dopamine and norepinephrine essentially in the brain. Again, no significant serotonergic activity. Some of the most important clinical pearls, this medication tends to be activating, which, if you understand a little biochemistry, a little biology, dopamine, norepinephrine, they tend to be a little bit more stimulating in the brain compared to some of the other kind of sedative downer type neurotransmitters. So again, bupropion tends to be more activating in patients, let's say with depression and they're very hyposomnolent. where they feel like they're sleeping all day, super tired, and that's one of their main signs and symptoms of depression. Bupropion might be one to consider in that type of situation. Another situation where I see this used is sexual dysfunction. I alluded to that before. Not having much or any of that serotonergic activity, that's going to help us avoid that sexual dysfunction adverse effect. And if patients are struggling with that with an SSRI, oftentimes you'll see them transferred over to bupropion. It's also approved for smoking cessation, also utilized in combination for weight loss. So we've got a few different purposes there where you might see bupropion utilized. From an adverse effect standpoint, think about that stimulation. So insomnia, agitation, worsening anxiety. These are all potential adverse effects with bupropion. Occasionally you could have some headaches, some dry mouth. And then one thing that always comes up on board exams is seizure risk. So if you've got a patient with epilepsy, you see them taking seizure medications, bupropion is generally a medication we're going to steer clear from using. So really pay attention to that. I know that's a recommendation that I've written numerous times throughout my career, just to be a little careful with this medication in patients with a seizure history, because the medication lowers that seizure threshold. A couple other things, kind of thinking about like risk factors for seizure disorder. So if anybody's got any type of brain trauma, brain damage, using a medication that can lower that seizure threshold, that may be a little bit risky there. Eating disorders, escalating dosages or overdose of bupropion, that's going to increase the seizure risk there potentially. Another clinical situation where you see seizures is alcohol withdrawal, or potentially can see seizures there. So again, starting, Wellbutrin or bupropion in that setting where we're withdrawing from alcohol, that's obviously a risky type of thing to do there. I alluded to the weight loss, weight neutral type effects of the medication. So that's a potential big advantage where I see this medication used most, and then the avoidance of those sexual side effects in addition to smoking cessation benefit there. So again, those best fit patients, again, depression, coupled with fatigue, or they feel over sedated or tired all day, that's a good fit there potentially. Patients really concerned about weight gain from antidepressants and or sexual dysfunction. And again, those contraindications, things you really got to pay attention to with this medication, as that seizure disorder. I've seen that asked numerous times on board exams, so definitely don't forget that one. Those eating disorders, it can increase that risk as well. And then any type of benzo or alcohol withdrawal, that can increase the risk of seizures and potentially be exacerbated by bupropion. All right, well, that's going to wrap up this podcast episode. Do me a huge favor, support the sponsor, meded101.com/store. All your purchases there to Amazon books, review courses, go directly to help me keep this podcast going. So greatly appreciate that. Find some good content there that have helped thousands of pharmacy students, med students, pharmacists pass their board exams and help them prepare to be a little bit better as far as medication management and medication safety goes. So again, meded101.com/store. Comments, suggestions, feel free to reach out to me, mededucation101@gmail.com. And of course, get your free Top 200 study guide. You can get that at reallifepharmacology.com. With that, I'm going to sign off. If you enjoyed this episode, do me a huge favor. Leave a rating, review on iTunes or wherever you're listening. And of course, share this podcast with other students, friends, colleagues, anyone who could benefit from some pharmacology education. Thanks so much. Take care. Have a great rest of your day.